But how lovely to see so many people here today. And thank you for taking time out of your Fridays to be here and to be here live, which is lovely. Um, I'll share my screen in a minute, and there are quite a few slides because there's a lot of material here. I'm hoping that even if you've been to one of my talks before and some of this is a bit familiar, um, some of it won't be because I'm always updating. Um, how I talk about this subject based on my increased experience of working with clients who are taking or withdrawing or who have withdrawn and are suffering from some permanent harm from having taken psychiatric drugs. So I'll try and blend in some of that experience as we go through. And I think it's just really important to say right up front that um, this is a talk primarily aimed at psychological therapists. Um, but lovely if you're not a therapist and you're also here, but that's who I'm primarily targeting this at. And we all have to decide for ourselves how and if we use this information in our practice, and it's always an individual decision for each client and for each session as to what's relevant to them. So I'm going to be talking about this in very general terms as to what the guidance says, and I'll be drawing on some of my own experience, but it's always subject to the normal frame of therapy and the relationship you have with your clients. So this isn't ever me saying this is how you must do it or should do it, or you've got to have these conversations or have this opinion, because we know therapy is not like that. So um, I'm going to share my screen, and I'll also flag when we can have some Q&As as well. There should be hopefully room for a couple of points during the presentation. So let me just share my screen and we can get started. So I'm hoping everybody can see that okay. I'm assuming Lucy will tell me if you couldn't. So our agenda today. So just checking in, why is it we need to know about this again? Some questions to kind of hold in mind whilst we're going through this material today about your own beliefs, experience, and knowledge. And it's really an important part of our own self-reflection, self-reflexivity in therapy, that we understand our own landscape when it comes to these topics. There's going to be a little bit of material around how psychiatric drugs such as antidepressants work, which I have recycled shamelessly from Professor Joanna Moncrief with her permission, obviously, and she wrote that section in the guidance. But I can also flag places where you can go and listen to Joanna directly on the subject. Then well, how does this all intersect with the practice of therapy? And I'm going to go through 5 main opportunities that we have to support our clients. I'm going to talk through 4 of those, and then we'll have an opportunity for Q&A. And in the Q&A, we're going to ask you to put potential questions in the chat, and Lucy will be having a look at those for me, pulling a few out. But please bear in mind, I'm not going to be able to comment on individual stories or cases because this isn't the appropriate forum for doing that. And also, as we know, we don't give advice on this kind of stuff. So a lot of this it's about the general information and the broad strokes about how we work with this topic rather than individual stories or cases. Then, so the second part, if you like, is really a bit more focused on withdrawal. How can we as therapists support clients as they're thinking about withdrawal, preparing for it, going through it, and afterwards? Then there's just a bit of time to think about, okay, well, so what about all of that? How might you integrate that with your practice, practically speaking? And then lastly, very much inspired by Joe's book, what are the options if you want to do more? I'm just sort of going to flag up a few of those options for you that you might want to consider if you're interested in doing something more on this. So let's press on. So, okay, why do we need to know about psychiatric drugs for our work as psychological therapists? Well, I don't think it's any big surprise to any of you that basically around 20% of the adult population are currently prescribed antidepressants. And when we consider drugs like benzodiazepines and Z drugs, and otherwise known as anxiolytics, and antipsychotics, that figure rises to a quarter of the population, which is just, staggering in terms of the number of people taking these drugs. Before we wrote the guidance for therapists, and this is working with the main therapy bodies, so BACP, UKCP, and the British Psychological Society, we did a survey of their members, just asking some questions about how common it is for them to be meeting with clients who are taking such drugs. And I don't think it's a big surprise to know that the figure is pretty high, 97% basically. We're working with people who are taking these drugs all the time. And it's important to remember as well that it's not only clients who might be taking these drugs, sometimes therapists themselves are as well. And it's important to be aware of what the impact of that might be for our work. Just a quick word about the therapy organisations involved. It didn't include the National Society for Counselling and Psychotherapy is the new name at the time. They weren't as big at the time. And obviously they've grown massively, but they do now endorse the guidance, even though they weren't involved very originally in getting it off the ground. So let's stop and have a think about the big picture in which the context for all of what we're going to talk about today. So, okay, so if we've got our client in the middle here, being very quite literally person-centered, and we're always in the midst of our culture. We're all immersed in that, and they have a number of very key relationships. They usually, but not always, will have a relationship with a doctor. And particularly if we are talking about psychiatric drugs, then there will be a relationship with a prescriber. And that prescriber will be bringing into that relationship their own training, experience, belief, and sometimes, and hopefully more often than not, guidelines about the conversations they have with their patients about drugs. And they will be giving medical advice. Now, that's underpinned by an informed consent process in that relationship. So a doctor is obliged or should be obliged to ensure that a patient has information, good information, complete information on which to base their decisions about whether they take a drug or not. I think we all know that often doesn't happen to the extent that it perhaps should do. And some of that might be about training, experience, and beliefs of the doctor, but very often it's about time and also the ability of the patient to hear it in that moment. There are also obviously very key relationships with family and friends that a client is in, and they will be also sharing their knowledge, experience, and beliefs about psychiatric drugs and about emotional distress. Very important, probably more important influences potentially on a client because they are of such long-standing relationships. And last but not least, there's our own relationship with the client through therapy. And we are bringing in our training, experience, beliefs, and knowledge about drugs. And that's absolutely what we're going to be thinking about and addressing today is, well, what do I believe? Where has that come from? And informing ourselves about the evidence. And the relationship in therapy is also informed by its own informed consent process, in which we are supporting our client's agency in making decisions for themselves about the therapy, so that they understand the impact of their own actions and choices on therapy itself. So that's a separate informed consent process to the one that happens inside the doctor-patient relationship. We may choose to give information inside our relationship, but we're giving information, we're not giving advice, and we'll talk more a little bit about that later. Last but not least, we've got drug effects. So in terms of the client and what they're experiencing, they could be experiencing multiple effects, and that could be from just taking them, or it could be from starting to come off them. So that's the big picture. There's a lot of influences on clients, and we need to bear in mind that we're just part of that bigger picture. Now, there are a number of different levels to which you can choose to engage with this subject. The first one is about understanding our own beliefs about drugs and educating ourselves on the evidence and just becoming more aware. And that's the most basic level of engagement that I'd hope that every therapist would be wanting to do. Excuse me. The second level is the one at which we're able to listen for our clients' experiences and beliefs about psychiatric drugs, to be tuned in to the kinds of things that might indicate what it is that they do think and believe about the drug. Third level is being aware of the possibility of withdrawal and feeling able to flag it, having the confidence to go, okay, I think I might be hearing something there that would be helpful to the client to flag it. The next level is being confident and feeling informed enough just to share information about how drugs work, possible effects, and even how to withdraw safely, but in very broad brush general strokes. And knowing where the good sources of information are that you might choose to signpost to your client. The deepest level is being able to support a client through withdrawal, and potentially even offering withdrawal-informed therapy after the worst is over. And that's the area, I've eventually found myself offering, although I'm not accepting new clients anymore because I'm trying to create space to work on actually creating services for people withdrawing from drugs. And if we have time, I will share a bit about that at the end. But it would be marvelous if there were more therapists out there who felt able to offer withdrawal-informed therapy, because there's an awful lot of people that need that. So this will be part of your decision making. Okay, what's my level of engagement going to be in my practice on this subject? So some definitions, just helpful before we get into the weeds, as it were. So dependence is when somebody's taking a medicine or drug, whether it's prescribed or not. The body views it as a foreign substance and tries to counteract its effects by adapting to it. So our system becomes dependent on the presence of that chemical in our bodies. When we're tolerant to a particular substance, over time, higher doses might be needed to achieve the same effect. I think we all might recognise this if ever we've drunk alcohol. We can recognise that we can build up tolerance or not have any tolerance at all, or it can disappear later on in life. Withdrawal. When the drug is stopped or reduced, the adaptations that our body has made to the presence of that drug are no longer opposed by the drug's presence. So this can lead to very unpleasant sensations and experience that get called withdrawal. So our system gets used to having something in it, it's not there, and sometimes it can take the body a long time actually to adjust to the drug no longer being there. And sometimes it can experience some level of permanent harm, particularly when people have been taking drugs for a long period of time, and if withdrawal is done too abruptly. The last definition I just want to add is addiction, and just to flag that this is different to dependence. Addiction, there's an added component where there is a compulsive preoccupation to seek and take the substance despite the consequences. Um, and it's a very different feeling um, around feeling I've got to actually find and take the drug as opposed to knowing that your body needs it. It's a different feeling. But it can be really helpful to understand the difference between addiction and dependence. And I think in the case of antidepressants, we're absolutely talking about dependence rather than addiction. So, just some key facts. All psychiatric drugs are associated with dependence and can therefore be hard to withdraw from. And the rule of thumb is the higher the dose and the longer people have been on it, the harder it might be to withdraw from. Evidence shows that around half of people will experience withdrawal responses, and for around half of those withdrawal experiences could be severe. Often, withdrawal responses are misinterpreted as the return of an original problem. And this can be both by the person who is trying to come off the drug, and also healthcare professionals can sometimes misdiagnose withdrawal as relapse. And sadly, often in those cases, prescriptions are reinstated on the misunderstanding that, okay, well, you must need this, I must need it for life. Sometimes prescriptions might need to be reinstated briefly in order to stop the experience of withdrawal, but then to allow a slower, more gradual taper off the drug. But that's different to being told that you need to be on them for life, which sadly many people have been. And just, I'm pretty sure all of you realize this, but clients taking or withdrawing from these drugs, they're not misusing them. They've taken psychiatric drugs as prescribed and found themselves dependent on them. Difficulties with drug dependence have been under-acknowledged over the last 30 years. I think that's, a clear understatement, quite frankly. And particularly the needs for psychological support for a physiological problem. I think it's important to make that distinction, and the specialist services needed. These have been very poorly recognised and to date not acted on in any large scale way, though we hope that that might be soon changing. So, whilst we are talking about this subject today, perhaps you can hold in mind, what's your stuff about psychiatric drugs? What do you believe about them? If you're a therapist, what's your relationship to the medical model? So, in terms of understanding the nature of emotional distress, what do we think gives rise to it? Where does it come from? And therefore, what's an appropriate response to it? That this will come from your training, but will be hugely influenced by where you practice and the experience you've had and the key influences on you. And so that's sort of worth identifying. Well, who are the current key influences on me and my work? So, if there was any, don't really believe in homework, but if there was any, thinking about this and identifying these consciously, I think could be really helpful, because it kind of then leads you to understand, well, how is this already in my work without me realizing it potentially? So we're now moving on to how do psychiatric drugs work? As I say, all of this is recycled from Joanna Moncrief's work, and there are some talks that Joanna's given on the main guidance website, and the address for that's on the bottom of the slide, prescribedrug.info. If you go under the training tab, there's lots of talks there, all available for free. So the accepted view, and you hope this is changing, but the predominant understanding out there is that drugs correct an underlying biological abnormality, that they have a normalizing effect. And this has historically been known as the chemical imbalance theory. And we now know, largely through a lot of work done by Joanna and other colleagues, that there is no evidence that any class of psychiatric drug works by targeting underlying biological mechanisms of any kind of symptoms. So the idea of chemical imbalances has been pretty much discredited, and many of the sort of psychiatric organisations have been trying to distance themselves from those kind of ideas. They're still to be found, sadly, in places, including on our current NHS website pages about antidepressants. There's something looks remarkably close to a chemical imbalance idea. So we don't know the mechanisms underlying any kind of underlying emotional distress from a psychological. Sorry, I'm just moving my Zoom window here because it was blocking my. There we go. Underlying any disorder or even any symptoms. From biologically speaking, psychologically speaking, I think as therapists, we could probably make a good stab at describing some mechanisms underlying the experience of emotional distress. Placebo-controlled trials do not confirm that drugs act in this way, the idea that they are acting on specific mechanisms, and any differences from placebo, the placebo effect can be accounted for in other ways. There, other evidence that drugs might have a mechanism targeting effects is lacking. So there's just a complete lack of evidence to support the idea that these drugs are working in that way. And there are other ways of explaining drug action. And this is a really helpful model that Joanna's developed, where she's got what she calls the disease-centered model versus actually a drug-centered model. And basically, the difference between the two is just rather than the idea of drugs acting on a disease, really she's saying that psychiatric drugs are drugs and they have an effect on us, and it's a question of whether those effects of those drugs are perceived as being helpful or unhelpful. So drugs in the drug-centered model are not seen as correcting an abnormal brain state. They actually create an abnormal brain state. They're not targeting specific diseases. They're psychoactive drugs that have psychoactive effects, like a range of other things that we might choose to ingest. The benefits or the therapeutic effects of the drugs, the idea in the disease-centered model is that it's supposedly arising from their effects on disease pathology. But actually, in the drug-centered model, the useful effects are a consequence of drug-induced changes to normal brain functioning. So it's simply a question of how do we feel when we take the drug? Do we think that's a useful effect or not? In the disease-centered model, an example would be, asthma treatment or insulin for diabetes. And in the drug-centered model, we all know the idea of drowning your sorrows by having a drink. That we ingest substances just to change how we feel, and essentially all psychiatric drugs. That's really the why we have an effect that they do. So it's simply that we're perceiving the effects on us as being beneficial, so we take them. Now, there's a very useful table in the guidance for therapists, which summarises the different drug classes, the effects that may be perceived, and I'm sorry, let me just go back up there. The possible withdrawal reactions that people might have when they come off those drugs. And it's useful just to read through that table and look at the sheer range of effects that people can experience when coming off the drugs. So, how does this all impact the practice of therapy. There are 5 opportunities we have to support clients. And the first that I'm going to talk about is that we can support the informed decision-making process and informed consent. And if we remember back to our slide around the big picture, there are 2 informed consent processes. There's that underpins prescribing and that underpins therapy. So we know that a doctor is responsible for the informed consent process for a client's decision about whether they take drugs or not. However, as therapists, we can check in with our clients about, well, what has the doctor told you? What was the information that you were given? What did you think about that? And if that process hasn't been as complete as it might be, or a client perhaps can't remember what they've been told, we could signpost them relevant information. So it's not our responsibility, this part of the informed consent process, but we can support it. And we're supporting the client's agency to ask questions. Sometimes they might be reluctant to go back and ask a prescriber questions that they forgot to ask or whatever, but we can certainly point them in the direction of where they can find that information. Now, underpinning therapy, the informed consent process in therapy, we can discuss the pros and cons of taking drugs whilst in therapy. And I think this is really helpful to understand that, because we know clients are already asking us these questions, well, they've been asking me them for a long time, that, you know, very often, even in a first session, somebody might say, I've come to see you, but my doctor's also suggested that I take antidepressants. What do you think of them? So these kind of questions are already in the room in many ways. We can, again, signpost relevant information about the pros and cons of taking the drugs. And again, we're supporting their agency to ask questions. So there's a lot of similarities between these 2 things. Just realizing that we're not responsible for the one underpinning prescribing, but we are responsible for the one underpinning therapy. Okay, so the second opportunity we have is to help, or just to explore the client's understanding of what they think's wrong with them, including what do they think drugs do versus how they think therapy works. So it's really, I mean, this is the kind of stuff that would happen in any therapy session. Why do they think they feel the way they do? As you know, what we're there to do is to help them explore and understand that. What have they been told by others? And who are those other people? How much credence do they give them? And I think this is where it's important to recognise the cultural position that doctors occupy. They are seen as, very often seen as, trusted providers of information. And so to be told something by a doctor has a particular power behind it. How do they understand drugs like antidepressants work? How long do they believe they need to take them for? Now, all of that also plays into, depending on the kind of belief system that our clients have, it plays into, well, if they believe drugs work in a certain way, how do they believe therapy works? And this may not be explicit, they may not have sat and thought about this, but it's important to kind of surface the assumptions that they make about how these 2 things might interact. Now, there are 2 ways of seeing the practice of therapy. And this might be a bit, you know, a step too far for some people today, but I'm just going to do a very whistle-stop tour through this. So in a drug metaphor, therapy can be seen as it comprising active ingredients that are supplied by the therapist to the client. And this is very often the model in which how randomized control trials can be done on therapy because the therapist client relationship is seen as okay, well, no, that's not important. What matters is what the therapist is doing with the client, what tools and techniques and strategies are being deployed by the therapist with the client, and there's usually a manual involved. And it's the assumption that it's those active ingredients that make the difference. The alternative is the idea of therapy as a dialogue. So therapy is this co-created dialogue between two intelligent, living, embodied beings. And it's basically a series of conversations. So these different views of therapy. The idea of therapy as a drug is, well, it's kind of general. It's a one size fits all. It's based on the therapist's skills and tools. There can be a standard manualized approach. Whereas therapy as a dialogue is responsive to the individual client, that it is very much based on the therapist's presence. And this is, often summarized in training as the difference between being and doing. Ooh. And in therapy as dialogue, we're very much reliant on professional judgment and broad relational principles rather than on techniques as such. Therapy as a drug is seen as an intervention, might even be described as a treatment. Whereas therapy as dialogue is about conversation and self-healing. Therapy, when seen as a drug, can often be seen as therapist-led as opposed to client-led. The idea of that it is a treatment, that it originates outside the relationship, as opposed to a practice that actually originates from within the relationship. Its benefits come from the relationship itself. Now, it's kind of important as to where your head sits, as to how you see what you offer if you're a therapist, as to which of these models feels like the right one for you. And it may be very different as to how other people around you see what you do, particularly if you work in a medical setting. But the most important thing to remember, actually, neither of these views is based on the idea that distress is biological in nature. All modalities, all ways of working in therapy assume the psychosocial causes of distress. None of them are based on a biological view. And it's really easy for this to get lost sometimes. And I'd just like to flag how important it is the language we choose to use to describe what we do, because how do we expect our clients to understand the difference, if you like, between what's happening physiologically and biologically versus what's happened to them rather than what's wrong with them, if we are using language which makes it sound like what they've got is something medical, is something biological? So rather than talking about us offering treatments or interventions, then maybe we talk about the fact that there are dialogues and conversations or relationships. We don't talk about symptoms. We might talk about clients' experiences. The use of the word clinical is problematic. We borrow an awful lot of language from the medical model, often in an unconscious way. And there's something, I think when you're first training as a therapist, the idea that you might have clinical practice or clinical supervision can make it feel rather important. But actually, it's locating what you do with a medical word. Whereas maybe talking about our practice and the fact that we have supervision, we don't need to use the word clinical. Do we have patients or do we meet with clients or people? Do we talk about conditions and diagnoses or understanding, having a shared understanding of why clients might be responding in particular ways? Now, of course, Clients might choose to use some of these words, and we need to be familiar with them for that purpose. But how we locate what we do and the conversations we have with our clients can make a huge difference to this um, perception that clients have of what's going on for them. Do we work in a consulting room, or do we have a therapy room or an office? Oh, so yeah, these choices, they're active choices, and don't fall into them. I remember one of my first training placements was in a GP surgery, and I turned up for my first client, and I was told that I had a clinic and that I had to log on to the system and I would see my list of patients. And I was working in a GP's consulting room, which had a couch and all the paraphernalia, medical paraphernalia in the room. And it just felt such a difficult environment to actually work in a person-centered way, which is how my training started out. And it was just so in my face that it just felt wrong, but it sort of was quite an informative experience for me. So just something to be aware of. Um, just a quick word about the idea of combined treatment, which is often talked about as being a very good thing, as though it's a gold standard somehow that if somebody is taking a drug such as an antidepressant and also in therapy, the idea that must be the best. But actually, there's very little evidence for that. It's really weak, actually, the idea that this is somehow a good thing. Um, and actually, the effects of or the beliefs about drugs can interfere with the therapeutic process. So, just trying to plant a seed, really, that every time you hear that and people are sort of assuming that it's a good thing, that to question it. So, the third opportunity we have to support our clients is to signpost information about drugs. So this could be highlighting the availability of certain types of information and knowing where the trusted sources are that you can point clients to, giving or discussing information from your own reading. And both of these are based on encouraging the client's agency so that, they're going and finding out information for themselves in order to make decisions or to have deeper conversations with prescribers about the drugs that they're being prescribed or recommended to take. Excuse me. So the distinction between giving information advice, and I found this really helpful when I was first starting out working in this area. Very clear distinction. You can share information from a reputable source. You can discuss scientific evidence. You can offer a different perspective. What we don't do, we don't offer diagnoses. We don't, when getting nowhere near prescribing, we don't advise on dosage or frequency in terms of individual personal advice to a person. And we don't offer personal advice on how to withdraw. We can offer the general information. And once you've got this distinction clear, it's very liberating because I think a lot of people can be very scared to talk about this kind of information with clients, afraid of not being seen to work within their competence. And these other scary phrases get used when we're training. But actually, if you're informed, we inform our clients all of the time, sometimes around how they might manage an anxiety attack, for example. We give information, we point them to trusted sources. So this is no different. And it's about making sure that we're adequately informed so that we feel confident in being able to inform our clients. The fourth opportunity we have is around exploring clients' experience of drug effects on themselves, on therapy, on others around them, actually, as well. And this can be when both taking and or withdrawing. And I'm going to talk a bit more about withdrawing in more detail later. But the potential effects of taking drugs, um, and this is probably a broader statement than just antidepressants, to be fair, but some people do experience antidepressants as numbing in a certain way, less tranquilizing, I think, for antidepressants, and sedating. That can be more your anxiolytics. But often access to emotions can be reduced, and sometimes that's why people say that they find antidepressants useful, is sort of the idea of taking the edge off or just numbing slightly. Um, of course, we must remember that they're not selective in terms of only numbing difficult feelings. They can numb all feelings. Um, and so people's experience of the world and of their relationships can feel slightly flattened in all different directions. So it can inhibit feeling the good stuff as well as the bad stuff. It's important to explore potential experiences when reducing a dose or choosing to withdraw from antidepressants. And to actually signpost information about what the range of those experiences might be. But the kind of things you might hear from a client might be, I tried stopping taking them, but I felt bad again, so I went back on them. My doctors told me I need to be on them for life. So these are signs to listen out for, that a client might have had an experience of withdrawal from stopping taking or reducing. And I guess that brings us to the sort of a bigger picture of, well, what are our clients already bringing into the room, regardless of how far you choose to read more on this subject or get involved in it, it's already in the room, because there can be this confusion in understanding of what drugs do versus how therapy works. Excuse me, these questions around, should I take them? Should I carry on taking them? The experiences of the effects, good and bad, and also the drug effects themselves and how they might impact therapy. Now, the final opportunity is around supporting a client through withdrawal and afterwards. But this is the moment where I'm going to pause. You'll probably be pleased to hear, because it's a bit death by PowerPoint. And we're going to have time for some Q&A. So I appreciate that's a lot of information I've just given you there. So Lucy, has anything been coming out in the chat that people would like to know a bit more about, or got any particular questions around?
So I'll give people a moment to type any questions that you have in the chat. It can be about anything that's come up in the first half of this webinar. I know it takes a few minutes to type, and then I'm sure people do have questions, and then I will read out a few of them. As Anne mentioned, she won't be able to offer kind of individual medical advice or advice about individual situations, but we could definitely draw out general themes.
And just while we're waiting for that to happen, we have now developed this whole series of talks based on the guidance, which are going to be used in trainings for therapists in universities across the country. And they're all available on the Guidance for Therapist website. You can have a look at them whenever you would like. So just to let you know that there's talks by all the authors who've been involved in the guidance, actually.
So I've just dropped that link into the chat.
Thank you.
There's a question here around finding a withdrawal informed therapist. Is there any kind of kind of database, or how would one know if a therapist is withdrawal informed?
Yeah, that's a very good question, and it's one that Joe and I have had a few conversations about. Um, both BACP and UKCP um, have a box that you can check on your profile to say that you are aware of issues around prescribed drug dependence. So it is possible to search on those databases for therapists who say that they are at least aware of the issues. I appreciate that there's a big difference between being aware of the issue and being able to work in a withdrawal informed way. And this is a broader conversation I've been having with Joe and also actually our some colleagues in America about creating a specialist directory of people who work with this issue. So it could be withdrawal coaches as well as withdrawal informed therapists. That doesn't exist yet. I think it's needed because I think it's really hard to find people. I've got a little list of people that I will refer people onto, but I think most of those people are already full up because the demand exceeds supply. But this is where I'm hoping all of you lovely people will help fill some of this gap, that if you are able to work in this way, to really clearly state it on your website. And if you have profiles with any directories, to try and make it as clear as possible within the categories you get that you work with this issue, because there's a lot of people there out there looking for this kind of support.
Thank you. There is a question around um, other types of drugs and substances, um, so cannabis or THC, and also some advice given by Dr. David Nutt, that might be, even preferable to prescribed drugs. Does that kind of feed into your message in the webinar, or could you
I
comment?
think I think it really, what Joanna Moncrief says holds true for any class of drug, that all drugs have effects and they are either perceived as helpful or unhelpful. Um, and the problem is with any drugs that come to market, they are not tested in the long term on people. They're mostly tested from a maximum of 12 weeks, the people taking them for 12 weeks. And that's simply not long enough to really understand how dependence forming they are and what the experience is of people coming off the drugs. So there are always a new set of drugs, which is heralded as being the next big thing from pharmaceutical companies. Um, they are all just drugs that have effects that are either helpful or unhelpful. So I think it's really important to say that the guidance is not saying drugs are bad, don't take drugs. They're just trying to give the evidence about how they do work, what they can do, and that in some circumstances, some of the drugs can be helpful. But I think it's that they are overprescribed generally at the moment, that they tend to be prescribed beyond guidelines, and that there's an awful lot of people who've been prescribed them historically who were given the information that was regarded as mainstream at the time about um, resolving a chemical imbalance, who really need the opportunity to review and update their understanding about what the drugs are doing and to be supported to make a different choice about whether they continue taking them or not. So it's not as I say, it's not an all drugs are bad suggestion at all.
Thank you. And Joe Watson also adds that there's a good discussion on that topic in the AD4E Festival playlist. So if you want to think more about that, that would be a good starting point. There's a couple of questions around signposting. I know it's hard to list lots of options, but what are good places to signpost for non-medical language? Or you talked a bit about language, like what are the options for non-medical language, and also what are the options for people if they're thinking about going on, so before taking a prescribed drug?
It's a good question. So I know that the British Psychological Society actually developed a language guide, which I think initially was aimed at journalists um, around alternatives to some of the medical language. And I'm sure that we can find the link for that and put that in the chat. It's the BPS language guide, and that was done by Peter Kinderman and Anne Cook. Um, what was the second part of the question? Sorry.
Um, Supporting people
Oh,
deciding
yes.
whether to go on, signposting for that.
Yeah. To be honest, I would say to read the leaflet. To read the leaflet in that comes with the drug. I think that's always useful to know. Um, the other thing that I piece of information that I always look up, and I think this is in the BNF, um, the formulary book, which is the number needed to treat, NNT. How many people need to take a particular drug in order for one person to get benefit? And the number needed to treat for antidepressants is between 7 and 8. So 7 or 8 people have got to take antidepressants for one of them to get benefit. And um, I think BNF is available online. I've just seen that pop up in the chat. Um, and it's just, whilst only one person might benefit, all 8 will be exposed to the potential harms of the drug. So I just think that if patients were given the full information about the kinds of risks that some of the drugs might present, I think a lot fewer people would choose to take them. One of those, which is getting more publicity and more awareness recently, and you may have seen articles in the press around, is something called post-SSRI sexual dysfunction, or PSSD. And this is where people can suffer really quite extreme effects, such as genital numbing, through taking antidepressants for very short periods of time, or as a result of coming off them. And it's not only effects in terms of experiencing feelings or having genital numbing. It can also be anhedonia, which is the inability to feel joy, the inability to feel pleasure in anything. And actually, I think this is the most, of all of the experiences that people have with these drugs, I think it's one of the most extreme. I'm going to mention that there is another one called akathisia, which I think is equally bad, but in a very different way. But where people simply are unable to experience joy or pleasure in anything in life, and that's just incredibly difficult to live with. Akathisia, I'll talk a bit more about under withdrawal. Um, and that's more an internal state of agitation where you cannot sit still, and it does not stop, and it can carry on for days and weeks and months, and it can be absolutely intolerable. And that's what drives people into A&E or even to take their own lives, sadly. So there are some very extreme things that people can experience through taking the drugs that I think people should be better informed about. There are a lot of resources flagged in the guidance. That's the other important point to say. There's an awful lot of, there's a whole list of sources of information for people in the back of the guidance. All right. So just looking at the time, I think what I'd like to do is go ahead with the second part of what I was going to talk about today, which is a bit more detail around withdrawal, if that's okay. And then we'll have another Q&A at the end. So any questions that arise during this, do pop them in the chat. Lucy will take note, and we'll make sure we've got time at the end to look at them.
Yeah.
All right, so I need to share my screen again, don't I? Okay. Now, the first thing we are going to do, sorry, I am just lining something up, so I am still here. The first thing we're going to do is actually listen to some people's experience of withdrawing from antidepressants. It's just a 5-minute film of people talking about their experiences, and it's just a really helpful way of kicking off this section. So let me just share my screen. Okay.
My name is Stevie Lewis. I'm a member of LEAP, the Lived and Professional Experience Advisory Panel for Prescribed Drug Dependence. I would like to introduce you to 3 women who will share their experience of taking an antidepressant: Liz, Sarah, and Sandra. My first question to them is, can you describe to us what happened in your interactions with your doctor?
Initially, I was on fluoxetine. I recognised that I was suffering sexual numbing. So I spoke to the doctor and asked if there was something else I could try, because obviously this was important to me. So she suggested 15 milligrams of mirtazapine.
In 2003, about 8 months after I'd given birth to my daughter, I'd gone back to work. I was working full time, and I started to experience incidents of panic and upset stomachs. My doctor said that I was suffering from social anxiety disorder, and he said to me that what I could do was take paroxetine, this wonderful pill which was going to address a chemical imbalance in my brain.
My mother had been diagnosed with full-blown cancer. She lasted 3 months, but actually the stress of those 3 months and with additional personal issues, I probably went into quite a depression. I was prescribed vortioxetine, and as soon as I started taking it, I was getting adverse reactions. I spoke to the doctor about this, and they increased the dose, which made it even worse, and akathisia then kicked in.
I asked him if I was going to get any side effects from having it, and I was told no.
What advice were you given by your doctor about stopping the drug?
So she said, for the next week, take one every 2 days for a week, and then you can stop.
I recall the doctor saying to me that if I was diabetic, I wouldn't be questioning taking insulin, and this is just like being diabetic. So keep taking the medication.
The GP advised to half them for a week and then to stop them. 48 hours after my last dose, I said to my husband, I want to kill myself.
By the end of the first week of skipping doses of that medication, I was so ill that I had to go back on it.
What was withdrawal like for you?
Bang, a whole host of symptoms hit, the worst for me of which was agoraphobia and intense 24/7 anxiety.
I felt like I had the flu, I could barely move. I felt really hot, but I was shivering. I had like a chemical anxiety. It was hot, like my skin was on fire, along with like uncontrollable panic. I joined a mirtazapine group to see if the symptoms were connected to coming off the drug, and it was soon confirmed that I was suffering withdrawal from discontinuing the medication, and I should reinstate and start a harm reduction taper. I rang my doctor about this, and she told me to get off the group. They don't know what they're talking about.
As soon as I stepped out the front door, I was hit with intense fear.
The anxiety and the fear was 24 hours a day, the inner akathisia. It's like being tortured in your own body, in your own mind.
How has being in antidepressant withdrawal impacted your life?
It's made me too unwell to work. That goes on to me claiming sick pay, which doesn't cover my bills.
It was the school summer holidays. My girls wanted me to go out and do things with them. I could not leave the house.
I used to be very outgoing, gregarious, and had lots of friends.
I used to go to the gym 6 days a week. I used to play football every Saturday. I'm not physically well enough to do these things anymore. Like, that has just been taken away from me.
I started to wonder about whether I'd made proper emotional attachments to my children all the time. I'd been on these drugs 14 years as it was by then.
I've been tapering for 22 months with a year to go. So that's 3 years to get off of a drug that I was only on for 4 months. I never asked for this, and I feel like there's no accountability anywhere. It makes me really angry.
What did you need from the health service that you didn't get?
A bit of compassion. It would have made my experience a little bit better than not being believed from day one. This could have all been avoided if I was aware of the trouble I could get into coming off of this medication.
I would not have gone on the drug in the first place. So informed choice, really. I think doctors didn't have a clue how to taper me off that drug.
They should have at least told me about the withdrawal, not sugarcoat it, that it will be over and done within up to 2 weeks.
All the information is online. There's the NICE guidelines, which I handed everything over to my GP. Medical professionals, I would say, need more training on this subject of how to advise a safe taper so they're all on the same page. They put you on, they should be helping you get off. I think just leaving us out there to rot with, having to go to Facebook groups is not acceptable.
So just really powerful, isn't it? Just hearing it from the people who've experienced it. And I think it's when you realize this is what's at risk for people, it just sort of makes it more important for us to just know a bit about this subject so that we can help people avoid suffering. Just knowing enough to be able to say, oh, if you're thinking of coming off your drug, this is something that, needs to be done, this is general information, it needs to be done very slowly. And just pointing to some really simple resources. I mean, the Royal College of Psychiatrists does now have a leaflet called Stopping Antidepressants, which actually does say that a long, slow taper is very often the way that people need to come off. Not everybody does. The trouble is knowing whether you're somebody who needs that or not, and the fact that you might be risking some of those more extreme reactions when you don't know whether you're somebody who can come off faster than somebody else. But getting ahead of myself. So let's go. I'm just going to go back into the presentation and we'll unpack this a little bit. Okay. So just reiterating what I said at the top of the workshop today, any intervention we make is always subject to the frame of therapy and the best interests of the client. You need to decide what's right for you and your practice. But we are often in a unique position to hear possible signs of dependence and withdrawal. If you think of the time that we spend with our clients and how much more what that is than most prescribers ever get to spend with their patients, we just have a very a different opportunity to hear this. And just being alert to its possibility and being willing to flag it could prevent or reduce suffering. Okay, so withdrawal. Well, when can withdrawal happen? Well, I think everybody's heard of the idea of going cold turkey, i.e. just completely stopping taking a drug that you've been taking for a while. And people might say something like, I tried stopping taking them, but I felt bad on again, so I went back on them. Pretty much any drug you stop taking cold turkey, you're going to feel some effects from doing that. Now, what a lot of people don't realise is sometimes when just missing a dose can be enough to start experience something of withdrawal. And occasionally people realise it. Now, sometimes what people say is, well, I really notice if I miss a dose, I must need them. That they think that somehow the drug is holding this wall of emotional distress at bay, and even if they miss a dose, that's what they're experiencing coming back through, rather than actually it's a symptom of withdrawal from the drug rather than re-experiencing of the original problem that they were prescribed for. If somebody has reached tolerance on a drug, so they might need to take more to have the same effect, they can experience withdrawal even between doses. I think that's less common with antidepressants, more likely to be true with something like a benzodiazepine, but it's certainly a possibility. Now, when changing drugs, very often when people are experiencing adverse effects when taking a drug, they might go back to their GP and say, this one doesn't really suit me. A GP sometimes they might just try increasing the dose, and sometimes they might say, oh, we'll come off that one, let's try another one. And they just cold turkey just say, we'll stop taking that one and start taking this one. And all drugs are not the same. All even SSRIs are not the same. Some people even report problems when changing the brand of the same drug. So it might be, in theory, the same drug in the capsule, but the name of it or the brand is different, or it's produced by a different supplier. Some people report those problems. They are less common, but they are definitely reported. Okay, so some of the most common withdrawal responses include this list, and there is a more complete list in the guidance, but it can be from what one might think of as relatively mild experiences, through to the most awful ones like akathisia, as I think it was Sandra was talking about in that film. Hallucinations, delusions, nightmares. Now, the electric shock type feelings can be a real surprise to some people. They're often referred to as brain zaps. That is a real experience of like electricity in your head, which is a very disconcerting feeling when people have described it to me. Very often people will describe withdrawal, particularly the emotional withdrawal feelings like anxiety, that they will use words like it's got a chemical feeling about it, or it's just a lot more intense than I've ever experienced before, just extreme states. So that can be a way of trying to help understand what might be going on for a client, is to sort of say, well, is it like something you've experienced before? And if they're saying no, and they've had any kind of change in their drug, then the first assumption pretty much should be that it's probably a withdrawal sign. And as I say, there is a more complete list in the guidance, both the long and the short versions. So how might we hear withdrawal when we're working with clients? My boyfriend says I must really need the pills. He can tell if I've forgotten to take them. We might ask, well, what is it that he notices? And I wonder if you'd considered the possibility that what you experience is the effect of not taking the medication, a mini withdrawal, rather than an underlying problem showing through. The effects of missing a dose or stopping taking these drugs is only now being more commonly recognised. So you're just raising a possibility, flagging some new information potentially. Another example might be, hopefully, our clients at some point will say to us, I'm really feeling a lot better. So, but I've decided to stop taking my medication. So clearly there would be a normal exploration we would do about what have they noticed themselves feeling and a decision that they're feeling better. But asking, well, what's your plan for coming off? Because sometimes people aren't aware that it needs to be done usually quite slowly and in a smooth, linear way, rather than in big steps down. So in the film, we heard people talking about taking pills every other day, or taking big steps down, reducing by 50% at a time. There's a style of tapering called hyperbolic tapering, which is basically taking it down incredibly slowly. And it's true that the lower you go, the slower you go. So the smaller the dose, the smaller the reduction needs to be. And actually, the received wisdom of people who've been through this, and there are many, many people who say this, that around 5% of your current dose is like the sort of safest way to try and taper, to try and come off, particularly if you've had any experience of withdrawal. Now, we would always say that, you need to go back and discuss this with your prescriber, because taper should always be done under the supervision of a prescriber. We are in a cultural moment, however, where not all prescribers necessarily understand this very well. And this is where people have ended up on Facebook groups, on all sorts of internet groups, very, very well-informed groups, who are teaching each other how to withdraw in a safer way than people are being unfortunately currently told through mainstream medical practice. However, information is becoming more broadly available. So this idea that, they've suggested I take one every other day has unfortunately been a very common practice. And this is where we would say, is, I'm not a medic, I can't give you medical advice, but I can highlight information. And there is evidence that some people doing that, taking every other day, can lead to triggering withdrawal reactions, and that a slow, smooth reduction can be more successful. I can let you have some more links if you'd like to look into that. And this is where normally I would flag up the Royal College of Psychiatrists leaflet on stopping antidepressants. And that's it's a handy leaflet that a client can take along to their prescriber. Now, sometimes we might also need to signpost information on withdrawal in the midst of what we might call normal therapy. So just sort of highlighting the possibility of withdrawal reactions and what they might be. So this is kind of information that applies to all therapists all of the time. This could crop up. This isn't specifically about working with somebody going through withdrawal. We might need to signpost trusted information. And notice that withdrawal, I'm talking about how it might be done in a safer way or the safest way. I think there are very few people who would say that there is any completely safe way of coming off these drugs, but there are some ways are safer than others. We might be able to offer support for their withdrawal journey, but we need to be very clear about that, if that's what they're deciding to do. And we can help them prepare, we can support them during, and we can support them afterwards. So I'm just going to talk through those 3 stages. So what can we do in those 3 places in the journey? Well, helping somebody prepare. I mean, this really is not rocket science, and we call it the common sense model because it really is based on that. So are they ready to begin? What are the components that make for a successful withdrawal journey? Well, what's their knowledge and beliefs about the drugs? Have they had any previous experiences of trying to reduce or stop? How did that go? What were the reactions of people around them? Do they have any specific fears about what might happen? As part of preparing, signposting the relevant information that we've talked about. Thinking through with them, well, who's going to support managing their taper with them, if that's the approach they're going to try? What are their options? Discussing the possibility and the nature of withdrawal effects so they know what to look out for, and actually benchmarking for somebody. They might, say, okay, well, where are you at before you start on this journey? What's your current level of experiencing anxiety feelings, or what's your sleep like? Just sort of benchmarking where somebody's at before they start. Flagging the difference between withdrawal and relapse, and how might we tell the difference? And this isn't easy. The best guide is always the client. Asking them, do you think this is in your normal repertoire for how you experience distress? What is currently going on in your life that might be causing distress? And to be honest, as I've said before, and this is very much based on the work of Baylissa Frederick, who is a pioneer in this field in terms of supporting people coming off psychiatric drugs. If in doubt, assume it's withdrawal, because the worst thing in the world that we can do is to locate the source of a problem with the person when it really belongs with the drug. A lot of people have felt gaslit, to use a popular term, when they have described their experiences to a healthcare professional, only to be told, oh, well, that can't possibly be the drug, it must be you. First assumption, anywhere near somebody changing their drug regime, it's withdrawal. But helping them identify their emotional repertoire, pre and post taking drugs, and to agree what an approach might be to new or heightened emotions. So again, elements of preparing. Well, who have they got around them? What's their support network? Are they a member of any groups? And there are some peer support groups. Most of them are online nowadays, actually, since the pandemic. And these might be both personal, professional, and peer networks. You could discuss the idea of using a diary or a log to track reductions and reactions. Now, this depends on, how complicated somebody's journey is and their previous experiences, but some people really like that sense of keeping track of things. Excuse me. It's important to be clear about your availability. Might you be able to give extra sessions or other contact if needed? And not being afraid of saying, well, no, if that's not possible. But it's just important to be clear. And that if they need support between sessions, what are their options? So during a withdrawal attempt itself, working with your client to help identify withdrawal reactions, normalizing what they're experiencing. Supporting their decision-making, encouraging them to go at their own pace whilst they continue to draw on medical advice. There's a very strong principle inside all NHS interactions, which is shared decision-making. And it's an absolute fundamental principle around withdrawal that it should be done at the pace which suits the patient, or in our language, our client. And if anything, there might be encouragement needed to take things slower. It would be very, 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 very rare to expect to have heard somebody to be advised to go faster. We may need to suspend work on deeper psychological material during periods when withdrawal reactions are strong, and we might just be shifting to providing support. Because it can be so hard at times to tell whether what somebody's feeling is about withdrawal or their own individual psychology, you can't at that point work on deeper stuff because you can't tell what's going on. So it may be about reassuring people that what they're going through will pass, understanding where they're at with their taper, how recently have they made a cut perhaps in what they're taking, what have they experienced, what information have they found out, what have they been told from other sources about what's going on, what are the choices that they're considering about what's going on. So there's a whole set of conversations, if you like, around the withdrawal process that we can absolutely be part of and support their decision making throughout. Quite often with people who are going through a difficult withdrawal, we might be trying just to preserve a bit of a window of hope, to say this will pass. Very often withdrawal experiences come in waves, and then somebody might experience a window when things are better. And usually people might stabilize in a window before then they would go anywhere close to making another cut in the drug that they're taking. So these sort of waves and windows, it can be difficult to remember that actually a window will arrive when you're in the midst of a wave, because people often feel swept away. It's a very good phrase, the waves and windows. They can be overwhelming, and people can lose hope at times. And sometimes just reminding people that they're in a process and that they've been through this step-by-step approach before might be the role we're needed to fulfill. and helping the client identify useful practices to help manage their experience. And we don't have to be an expert in all of these things, but knowing that there's a list of things that might help and that people have found before. There are Facebook groups full of people who are prepared to share their experiences of what they found helpful during withdrawal. But helping clients find the things that work for them, that can be part of our role. And you know, the biggest thing, as ever, is continuing to provide that warm and attentive relationship, helping the client adjust to their non-drug mediated self. And that's sort of when your people are sort of getting towards the end of a withdrawal journey and they're starting to re-experiencing themselves and working out, well, who am I now that I'm not taking the drug anymore? And that's kind of the next stage, really, after withdrawal is complete. So if somebody's experienced cognitive problems, so things like brain fog, which just can be impossible to try and make decisions, it may take a while for confidence in decision making to build again. We can try and make sure that clients' assessment of their progress and how they're setting their aims about life, actually, and therapy, making sure they're realistic, given their experience of withdrawal. Cutting themselves some slack, actually. It can take a long time to recover from this process. If somebody's unfortunate enough to experience real problems, it can take years for people to come out the other side, and they will be different as a result. We are always different as a result when we go through something big, and withdrawal can be that. And if it was considered traumatic, well, that might need to be considered in its own right in any further therapeutic work. Learning to trust medical professionals, again, can be a huge part of that. And of course, we all need to be able to trust medical professionals for other things that go wrong with us. And this can be a huge area for discussion and for work post-withdrawal. But also to be aware that post-withdrawal reactions can occur for quite a long time after stopping. And some people's experience protracted withdrawal. This is sometimes called post-acute withdrawal syndrome, or PAWS, PAWS. It can go on, excuse me a minute. It can go on for quite a long time after stopping taking the drugs. So that was withdrawal. There's a lot of information there, and the 3 different stages. So how might we reflect this in practice? You'll need to decide for yourself what kind of interventions you might make, taking into account your way of working and your setting. And any of those decisions and interventions are always subject to the frame of therapy and what your client needs. Perhaps think through your client list. Where are each of them in relation to prescribed psychiatric drugs? You might not know. They might not have told you. Might there be any issues to take to supervision to explore? Consider any areas for further reading you might like to do. And there's a list in the guidance, and I've also got some suggestions on the slides, which you'll be sent a copy of after today. And this is a big plea. Update your client-facing information to say that you are aware of issues of prescribed drug dependence and withdrawal, so clients can find you. If after today or later, if you do any more reading, you decide that you would like to do more in this area, then one of the things you can do, and this is either as a as a psychological therapist or as somebody with lived experience of withdrawal, or both, of course, you can register with LEAP, the Lived and Professional Experience Advisory Panel for Prescribed Drug Dependence. And it was set up to make sure that the moment the NHS was starting to develop services for people going through withdrawal, we had a list of people who were prepared to share their experience with NHS trusts, or integrated care boards, as they're called nowadays, to help them devise services. So if you think you might be interested in doing that in your area, register with LEAP. There's a meeting coming up on the 6th of December being organised by the Psychotropic Deprescribing Council. Now, that's an American organisation, but it's been set up by the person who set up a huge website called Surviving Antidepressants. And Adele is trying to bring together coaches and therapists who work in this field to decide, well, what do we need? What might be helpful? Do we need a certification, perhaps? Do we need a register? Do we need supervision? Do we need dedicated peer support for doing this work? What is it that we as therapists need? And what do coaches need? And what do our clients need to help find us? That's only just starting out. So the first meeting of that is going to be on the 6th of December. And I'm going to be at that meeting if anyone's interested, but you need to register via that link. And of course, read more. There's always more to read. And last big thing is get in contact if you think you might be interested in helping training others. If there's, we'll go to Q&A in a second, and I can share a bit more information about a potential project that we're working on with the NHS at the moment, which is still in its early stages, but has the potentially to be quite big. And I'm happy to share some information on that if that might be of interest. Oh, so sorry about the coughing and needing to drink a lot of water. How are we doing, Lucy? Have we had any questions come through the chat yet? Where are we at?
So one more question did come through the chat, and I'm also aware that there were a couple of questions, or more than a couple, that we didn't get to from before.
Okay.
So I could always ask one or two of those now, and I'm sure some more questions will come through while we chat.
Yeah.
One of the questions was around GPs training, and we've talked a bit about earlier in your talk, you mentioned that a client might have a relationship with a prescriber. What do we know about GPs training in this area? What information are they given?
My understanding is that there's very little in the routine training for GPs about withdrawal. The state of knowledge of a GP will largely be down to whether it's something they've gone and done some CPD around. A bit like, you've all chosen to be here today to learn a bit on this topic. GPs have a requirement to do CPD, and they might choose or whatever to be involved in and learn more about this subject. However, I'm doing some work with a colleague, Dr. Mark Horowitz. Some of you may have heard of Mark. He is the person who has championed hyperbolic tapering, and it was the subject of his PhD. And he's co-authored a book called the Maudsley Deprescribing Guidelines, which actually list all of the tapering schedules for how to more safely deprescribe. From this first volume is antidepressants, benzodiazepines, gabapentinoids, and Z drugs. And I know that he would like to do a second volume around other types of drugs. And he and I have been working on a project with the NHS, particularly the specialist pharmacy service. And we are creating web pages around withdrawal, better information about and signposting for primary care prescribers and pharmacists about how to more safely deprescribe. And there are tools, and we're hoping very much that this will roll out to a small number of ICBs next year, and with a wider take up then after that. So this could be an absolute game changer for antidepressant withdrawal in this country, to actually provide accurate, useful information and tools to prescribers based on the Maudsley deprescribing guidelines. So there's a tool that actually helps a GP identify the speed of taper that somebody needs, and also the individual steps that they need to actually do it. I mean, it could be huge, but you know, it's early days, and there are still a few hurdles that we've got to overcome to get there. So GP training is going to be a huge part of that. Sorry, come back to the question you actually asked me. We will be absolutely devising training to enable primary care physician GPs to engage with that.
Thank you for sharing it. It is so exciting to hear about it.
It could be, you know, there's always, you know, things that can go wrong. So I want to sort of under promise, over deliver on this.
I understand it's a process. It links to another question about, is there currently any list of psychiatrists who could oversee hyperbolic tapering, or would there be?
I'm not aware of one. There isn't one. More and more are aware of it. And I think it's important that people ask, are they aware of it, and are they prepared to help support somebody do a hyperbolic taper? Now that the Maudsley deprescribing guidelines have been published, there's something very concrete, if you like, that anybody can take to their prescriber to say, I've read about this, there's this guidelines, can we talk about me coming off in accordance with these guidelines? So no, there isn't a list, I'm afraid.
Another similar question, but what about if somebody is working with either children or families or parents of children who are prescribed a psychiatric drug, an antidepressant, something?
The guidance itself is aimed at adults, is for adults. I think we all know in this field that working with children is seen as a separate area that requires separate training, if you like. However, a lot of the issues that we're talking about are the same. There are unfortunately quite a lot of children who are prescribed these drugs. The guidance, as I say, is only aimed at adults. I'm not qualified in child psychotherapy to be able to comment on it specifically. So I'm sorry if that sounds a bit like a political answer. It is fraught. And to be honest, the only information I'm aware of, and where I would point somebody, is to actually Sami Tamimi's writing. So Sami is a child psychiatrist, and he's written many books on the subject of critical psychiatry. And I would be very surprised if he hasn't also written something around prescribed drug dependence. I'm sure he has. So I would point to Sami Tamimi, his writings, for somebody who wanted to learn more.
I've just typed his name in the chat.
Thank you. Yes, it's not a common name. Yeah. He has, I'm just looking for the book on my desk, because he's written one of the very straightforward guides to, let's have a look, I'll find it quickly. Yes, here we go. Children's Mental Health Problems, a straight talking introduction to, very accessible little book. Always handy one to have on your desk.
That was also updated a couple of years ago, so there's a new edition.
Yes, I think that is the new edition, but yes, you're quite right. Thanks, Jo.
I'll try and find the link for that and put it in.
Super. I mean, the whole straight talking introduction to series is great. And Joanna Moncrief has certainly got one on there as well, which we used as the basis for the guidance for therapists.
Someone's asked, what's the connection with funding and drug company interests in this area?
Well, now that's a topic, isn't it? That's a huge topic. It's not something I would say I'm a particular expert on. The area in which I'm sort of most aware of how this intersects really is the whole process for how drugs are licensed in this country. So through the MHRA. So something that I've learned through doing this project with the NHS. So in order to do a successful hyperbolic taper, most people will need access to a liquid antidepressant in order to achieve the small enough dose. But antidepressants, liquids, are only licensed for treating depression. They're not licensed for withdrawal. Now, that blew my mind when I first heard that. So it can give rise to sort of a very practical issue. So if you're getting a bottle of liquid antidepressant, it comes with a syringe that can measure doses of 5, 10, 15 milligrams, because those are the kind of doses that people take the antidepressant in. But if you are trying to do a taper, you might be trying to achieve really, really tiny doses of less than 1 milligram. And of course, that syringe is too big. If the box already contains a syringe, a pharmacist will not be paid, will not be funded to provide any other syringes. So this is just an example of the kind of thing we're trying to unlock in this project is, well, how do we make sure that pharmacists can be reimbursed for providing the size of syringe that people need to achieve these kind of small doses? But it's an example of how drugs have been licensed to be taken without any thought to how people are going to safely come off the drug. And I think we have to attribute that to being in the interests of pharmaceutical companies for people to take the drugs rather than to be able to come off the drug. I don't think I'm saying anything particularly controversial in saying that. So I think there are huge issues, for example, around how the MHRA works. And one of the things that the all-party parliamentary group for Beyond Pills has on its very long things to do list is to look at a Sunshine Act for the UK. So in the States and in Europe, I think, in France, mainland Europe, it's a requirement for doctors to declare money they receive from pharmaceutical companies for making speeches or writing papers. It's not a requirement to disclose it in the UK, apart from through conflicts of interest statement. But to be able to actually look up any doctor to see how much money they take from pharmaceutical companies, I think is a hugely important first step in, hence the name Sunshine Act, of shedding light on actually the state of interaction between pharmaceutical companies and the medical profession. Sorry, long answer.
I know it is a big topic.
It's huge.
It's really interesting to hear how those kind of material things do play into people's lives and into your work as well.
Yeah.
With therapists. So I'm going to ask two questions which are sort of related. So I'll ask you them together and you can kind of answer however it feels right. It's sort of taking you back to the actual work of working with clients. Someone's asked, what are your thoughts on working with trauma, which may well manifest in physiological effects, and how to distinguish between what is psychological in origin and what is drug withdrawal effects? I know you have talked a bit about that in the second half, but and the second question is, do you believe that people can benefit from therapy whilst perhaps numbed or sedated by drugs?
Okay. I think that the second one is the easiest one in a way, so I'm going to deal with that first. It's so individual to the client. And it really comes down to working with the client, listening to them, understanding where they're at. And sometimes you get to learn, you get to hear when people find it difficult to go to somewhere, where people find it difficult to bring experiences or emotions into the room, you would work with the client. But if they were repeatedly or over an extended period of time unable to access emotion, then you might start thinking about, okay, if they are on one of these drugs, you might start to say, okay, how far might this be having playing a role, and that opening up that discussion. So I would say that there's always a conversation to be had. There's always a relationship that can start to be formed. But at some point, a client might need to decide that they want to come off a drug in order to have greater access to emotions if it is getting in the way of them being able to be in touch with what's going on. So highly individual. So it is a very much it depends on the client answer, as you would expect probably. Remind me of the first one. So it was about trauma, wasn't it?
Yeah, so what are your thoughts on working with trauma, which may have physiological effects or manifest physically? And how do you distinguish what is psychological in origin with what is drug withdrawal effects?
Yeah, no, it's a very good question. And how far you're able to explore it, of course, depends on where the client is. And you're always guided by the client in any of these situations. So very often there is an exploration of, well, what's somebody's story? What's been their experiences before they started taking the drugs that are being prescribed them? So that you can kind of get a sense of who they were, what they'd experienced, what issues they'd had before the drugs came into play. And then there will be an exploration around how did taking these drugs help, hinder, what's been your experience of it, so that you kind of build up a picture of what somebody's sort of, you might call within their normal repertoire for them of emotions, what's been the major events that have happened in their life. And so you start to get that context that enables you to have some working ideas around, okay, this might be more about this event, but it might be exacerbated by somebody's then experience of withdrawal. So sometimes the withdrawal journey, as we've already noted, it can involve feeling a bit gaslit, that your experience has been denied. So if you've already had an experience earlier in your life when that was true, and that might be part of a traumatic set of experiences, then that might then be amplified by withdrawal. So it sometimes it's not just one thing or another. It might be an original experience, if you like, and a response to that, plus withdrawal on top. And this is where, therapy is often about archaeological layers, isn't it? About trying to understand how one experience has fallen in on top of another, on top of another. With withdrawal informed therapy, you're always bearing in mind that something might be physiological in nature when it might have been come from withdrawal, and trying to make sure that you're always taking that into account so that you're not inadvertently saying something is about the person rather than the drug. But you develop a shorthand with your clients on this because they understand that you know about withdrawal. And so they might say, actually, I only started experiencing this through my withdrawal journey. So once you have that trust between you, that you can hold that distinction, if you like, it becomes a lot easier. So we've got about 6 minutes left. I don't know if there were any other questions.
There are quite a few other questions that we haven't got to. So I'm very aware that, yeah, this is sometimes with webinars, it's
Do you want to just pick a last one, perhaps? Because I appreciate that we, might need to wrap up and.
okay. Someone's asked, could you say a bit more about how there isn't good evidence for the combined model of psychiatric drugs plus psychotherapy? They were just curious, about what you said before, that it might not be that it's sort of considered a gold standard, but maybe there's not good evidence for that.
There's something in the guidance on it. I would say go and look there because we brought all of the evidence together and tried to summarize what's there and what isn't there around it. And I think this is a personal view that I think the idea of combined treatment being the best was a convenient way of kind of smoothing over the quite big contradiction between saying to a patient, you need to take this drug, you've got a chemical imbalance, but at the same time go and talk to this person. Because if you genuinely believe somebody's got a chemical imbalance, then talking's not going to change anything, is it? Excuse me. But I think logically and intuitively, we all understand that bad things happen to people, to quote John Reed, and that people feel bad as a result. And I think doctors have always known this, that there's huge cultural determinants like poverty, health inequalities, discrimination. I mean, there's just a huge list of things that causes distress in people's lives, which very clearly is nothing about anything biological. But I think it's been a convenient, oh, well, the best, let's do both. When actually, I think the logic for prescribing a drug was never very strong in a lot of cases. But it's always been because therapy can take time and resources are finite. Sometimes it's been easier to reach for a prescription pad and that there haven't been the alternatives available for GPs to offer. So you can understand how we've arrived at where we've arrived at. But we need more creative responses to emotional distress. We need to act on the real causes politically. This is not just about providing more therapy. I don't think that's the answer at all. We need to consider the social causes of distress and make sure they are acted on. And certainly in the UK, we know that there is an intent with the new government to consider how distress is impacted through all government departments. It's not just a Department of Health issue. So through movements like the social prescribing movement as well, there's a greater recognition that there are more levers we can pull than just drugs and therapy. So, all right.
Thank you. That makes sense. And you've summarized such big topics. I feel like you've summarized them so clearly and covered so much ground.
There's always so much more to read on it. So, if it's something that interests you, do have a look at the list of books and go and do a deep dive because it's fascinating stuff.
Yeah, absolutely. And I'll try and pull the links. So we won't share the chat, but I'll try and pull the links out of the chat to share around. So many people are saying that they found this really, really, really informative, really thought-provoking, really valuable, that you gave brilliant answers. So I think I can safely say that people have got something from this webinar. And I was going to say, can everyone unmute themselves, or I'm going to ask everyone to unmute, and we could do a round of applause.